Welcome, learners, to another deep dive. Have you ever paused to appreciate the stunning precision of our body's immune system, that intricate defense network keeping us safe? Today, we're going to explore what happens when that precision, that incredible cellular intelligence, goes wonderfully, wildly awry, leading to a truly fascinating and deeply complex group of conditions.
Indeed. We're talking about a family of related blood cancers that originate from, well, a crucial component of our immune system, the plasma cells. This is a field of relentless discovery, a vibrant blend of fundamental biology and truly cutting-edge treatments. Our mission today is to take you beyond mere information, to leave you feeling genuinely insightful.
Insightful, yes. Almost like you've spent years immersed in the lab or the clinic.
Exactly. It's about grasping not just the what, but more importantly, the why it matters and the how it works at a truly professional, elite level.
That's our ambition, absolutely. Our deep dive today plunges into the intricate world of plasma cell disorders. We'll meticulously unpack everything, from the basic building blocks of our immune defenses, those remarkable antibodies, to the specific diseases like multiple myeloma and Waldenström's macroglobulinemia. We'll understand how they manifest, how we diagnose them with remarkable precision, and the extraordinary ways medical science is learning to treat them. Our insights are meticulously drawn from our stack of sources with a particular focus on Chapter 111, which provides us with an indispensable roadmap to truly master this information. Okay, let's unpack this. We're talking about plasma cell disorders. What exactly are these conditions, and why are they grouped together under this umbrella term? What's the common thread?
Right. At their very core, these are a group of monoclonal neoplasms. Imagine monoclonal as meaning they all, without exception, originated from a single abnormal plasma cell. That's the defining characteristic.
Single cell gone wrong.
Precisely. They're all related because they develop from common progenitors in what's called the late B lymphocyte lineage. So they stem from a specific type of white blood cell that normally plays an absolutely vital role in our immunity, producing antibodies. What makes them disorders is that this normal beneficial process has, well, gone rogue.
So they're like a family of related conditions, a cellular rebellion stemming from one original mistake. What are some of the key, perhaps most prominent members of this family that we'll be focusing on today?
The main ones we'll delve into are multiple myeloma, Waldenström's macroglobulinemia, primary amyloidosis, and the unique group known as the heavy chain diseases. You might also hear them referred to by a variety of synonyms in clinical discussions or research papers. Things like monoclonal gammopathies, paraproteinemias, plasma cell dyscrasias, or dysproteinemias.
That's quite a list.
It can indeed be a bit of a vocabulary challenge, but they all ultimately point to the same underlying issue, a dysregulation or loss of control in the normal function and proliferation of these plasma cells.
You've used that phrase, loss of control. Can you elaborate on that aspect? How does this normal, tightly regulated process become so utterly dysregulated in these disorders?
Exactly. Under normal circumstances, mature B lymphocytes are stimulated by a very specific antigen, say a virus or a bacterium, to then mature into antibody-secreting plasma cells. They then proliferate, but in a highly controlled manner, specific to that antigen they encountered. It's an exquisitely precise, self-limiting process.
Tightly controlled?
Very. However, in plasma cell disorders, this exquisite control is simply lost. The cells proliferate uncontrollably, forming tumors, and often, critically, secrete excessive or abnormal products. These products can be entire misfolded immunoglobulin molecules, or just their subunits like free light chains, or even signaling molecules called lymphokines, which can further fuel the disease or cause systemic effects.
And what are the broad, overarching consequences of this loss of control, this cellular anarchy? How do these disorders manifest and ultimately show up in a person, impacting their health and daily life?
Well, the clinical manifestations fundamentally relate to three primary consequences. Understanding these gives you a comprehensive picture. First, there's the sheer physical expansion of these neoplastic or cancerous cells within the body, often in the bone marrow. Second, the secretion of their abnormal cell products, which, as I mentioned, can be whole immunoglobulin molecules, their subunits or lymphokines, causing systemic toxicity. And third, to some extent, the host's own immune response, or often lack thereof, to the tumor. These three factors combine, really, to create the diverse, often debilitating symptoms we see.
Before we dive deeper into specific diseases, we need to talk about what these plasma cells actually make. Immunoglobulin molecules, more commonly known as antibodies. These aren't just proteins, they're the core of our immune defense, and understanding their structure is crucial to understanding these disorders. What's fascinating here is how we classify them.
It's absolutely foundational. Truly understanding these molecules provides a master key to the entire field. Immunoglobulin molecules have three categories of structural variation that define their antigenic determinants, and these are meticulously used to classify them. First, we have isotypes.
Isotypes, okay.
These are determinants that distinguish among the main classes of antibodies within a given species. Crucially, they are the same in all normal individuals of that species. They are recognized by antibodies from a distinct species, but not from the same species. In humans, we have 5 heavy chain isotypes, M, G, A, D, and 2 light chain isotypes, kappa and lambda. These define the general type.
Got it. 5 heavy, 2 light.
Second, there are allotypes. These represent more subtle, distinct differences determined by allelic genes, meaning variations in genes that exist within a population. By definition, they are detected by antibodies made within the same species, as they are genetic variations within our own species.
Okay, so variations within humans.
And finally, the most specific and perhaps most profound for our discussion, idiotypes. These are truly unique individual fingerprints of the molecules produced by a given clone of antibody-producing cells. They're formed by the precise, unique structure of the antigen-binding portion of the molecule.
So if I'm understanding this, the idiotype is like the individual fingerprint of an antibody, right down to a single clone of cells. That's an incredible level of precision. Tell us about the actual physical structure of these molecules. What do they look like?
Think of an antibody molecule as a Y-shape. It's a complex protein, composed of 2 identical heavy chains, each weighing about 50,000 molecular weight, and 2 identical lighter chains, each around 25,000 molecular weight. Each of these chains has a constant portion, providing the structural backbone. But then crucially, they also have a variable region with extensive sequence variability. The heavy and light chains are intricately linked together by strong disulfide bonds, and they align perfectly so that their variable regions are adjacent.
And why are those variable regions so important? What makes them the absolute core of an antibody's function, its very purpose?
Because that variable region forms the precise antigen recognition site. It's where the antibody perfectly latches onto its target antigen, like a specific key fitting a unique lock. This allows our immune system to identify and neutralize countless threats. And crucially, its unique structural features are what form those idiotypes we just discussed.
Ah, okay, the fingerprint part.
Exactly. This makes idiotypes incredibly reliable markers for a particular clone of cells because each unique antibody with its specific idiotype is formed and secreted by a single distinct clone.
It sounds like a complex genetic process is at play to create such a specific molecule. How does the cell ensure this absolute specificity, this singular focus on one type of antibody?
It is indeed a marvel of genetic engineering within our bodies. The mechanics involve sophisticated gene rearrangements. VDJ joining for the heavy chain, VJ joining for the light chain, essentially our body shuffling and selecting gene segments to create immense diversity. What's truly remarkable is that a particular cell clone performs these rearrangements uniquely and on only one of its 2 chromosomes.
Only one chromosome?
Yes, to produce an immunoglobulin molecule of only 1 light chain isotype and only 1 allotype, a critical process called allelic exclusion. This ensures the absolute specificity of that clone. After exposure to an antigen, the variable region may also become associated with a new heavy chain isotype through a class switch, allowing the same antibody to perform different functions. Each clone performs these sequential gene arrangements uniquely, resulting in a unique immunoglobulin molecule, a molecular signature.
So these plasma cells are essentially antibody factories turning out these incredibly specific molecules. But do they ever produce just parts of antibodies, perhaps as a byproduct?
Yes, they do. And this becomes a very important diagnostic feature. In most plasma cells, light chains are synthesized in slight excess relative to heavy chains. These excess light chains are then secreted as free light chains and are normally rapidly cleared by the kidneys. Under healthy conditions, less than 10 milligrams of these free light chains are excreted per day.
Less than 10 milligrams.
Right. So this becomes an incredibly important diagnostic clue when we see higher amounts in blood or urine. It can indicate overproduction by a clonal abnormal plasma cell population, even if a full M component isn't present.
One of the earliest and most fundamental ways to detect these disorders involves a laboratory test called electrophoresis. This is where it gets really interesting, because it's about visualizing these proteins. What exactly does it show us?
Electrophoretic analysis lets us separate serum proteins by their movement in an electric field based on charge and size. Normally, the diverse array of immunoglobulins, all the antibodies your body makes, move heterogeneously. They spread out, forming a broad diffuse peak in the gamma region of the tracing, like a gentle hill.
A broad hill.
Exactly. In patients with plasma cell tumors, this broad gamma peak is usually increased, reflecting a general rise in immunoglobulins.
But the key signature that really screams monoclonal is something more specific, right? The M component. This is what everyone in the field talks about.
Precisely. In monoclonal gammopathies, where a single abnormal clone dominates, the product from that clone is identical. This uniformity produces a very sharp, narrow spike in this region, which we distinctively call an M component, emphatically standing for monoclonal.
A sharp spike, not a hill.
Right. Less commonly, this M component can appear in the beta-2 or alpha-2 globulin regions. To be quantified accurately by this standard method, the monoclonal antibody must be present at a concentration of at least 5 grams per liter, which roughly corresponds to a tumor burden of about 109 cells actively producing that antibody, a significant accumulation.
So if you see that characteristic sharp spike on electrophoresis, how do clinicians confirm it's truly monoclonal and not just a high concentration of normal polyclonal antibodies?
Confirmation involves a more precise technique called immunoelectrophoresis, or immunofixation. These use specific antibodies that react with different heavy and light chain types. By doing so, they reveal the presence of only a single heavy and/or light chain type, definitively confirming its monoclonal nature.
Okay, so electrophoresis gives quantity, immunofixation gives quality.
Exactly. Electrophoresis provides the quantitative assessment how much is there, while immunofixation provides the qualitative confirmation what type it is, and that it is indeed monoclonal. Once confirmed, the M component amount is a reliable measure of tumor burden, an excellent marker for managing therapy.
So an M component, that distinctive spike, sounds like an undeniable red flag, a definitive sign of myeloma. Is it truly that straightforward, or are there nuances?
That's a critical question. The presence of an M component is not always indicative of myeloma. This is a crucial distinction. While it's an excellent tumor marker for patients already diagnosed, it's not specific enough to be used as a screening tool for asymptomatic individuals. M components can show up in a surprisingly wide range of other conditions.
Really? Like what? Give us some examples. This broadens the picture significantly.
Right. Beyond the obvious plasma cell disorders, M components can be found in other lymphoid neoplasms. CLL, various lymphomas, both B or even T-cell origin. They also surprisingly show up in non-lymphoid cancers. Chronic myeloid leukemia, breast cancer, colon cancer.
No, even non-blood cancers.
Yes. And even a variety of non-neoplastic conditions can be associated with them. Cirrhosis, sarcoidosis, parasitic diseases, Gaucher's disease, pyoderma gangrenosum, and several autoimmune conditions like rheumatoid arthritis, myasthenia gravis, cold agglutinin disease.
Right.
We also frequently see them in immunosuppressed patients after transplants. It really speaks to profound immune system changes.
That's a truly extensive list. Any other surprising or perhaps very rare associations that highlight the M component's presence beyond the expected?
Yes, there are at least 2 very rare skin diseases distinctly associated with the monoclonal gammopathy. One is lichen myxedematosus, or papular mucinosis, where IgG deposits in the dermis, possibly an antibody-targeting skin. The other is necrobiotic xanthogranuloma. Histiocytic infiltration, usually on the face, forms nodules. About 10% of these patients, surprisingly, progress to myeloma.
10%? Interesting.
Also, about 5% of patients presenting with an idiopathic sensory motor neuropathy also have a monoclonal paraprotein, showing systemic reach even into the nervous system.
So the M component itself can vary. Is it always a complete intact antibody, or can it take other forms?
It can vary. It might be an intact antibody molecule, any heavy chain subclass, or it could be an altered antibody or just a fragment, for instance, in solitary bone plasmacytomas, or when only isolated light or heavy chains are produced. Less than 1/3 of patients will have an M component detectable by standard serum tests. You might miss it.
And you mentioned Bence-Jones proteins earlier, those excess free light chains. Where do they fit in?
In about 20% of myelomas, only light chains are produced by the tumor cells. These are secreted into the urine as Bence-Jones proteins. Crucial markers. Regarding the frequency of heavy chain class in myeloma, it's roughly proportional to their normal serum concentration. So IgG myelomas are more common than IgA and IgD myelomas, just mirroring their natural abundance.
What about patients where no M component is found at all, neither in serum nor urine? Does that mean they definitely don't have a plasma cell disorder?
It's rare, less than 1% of patients, but it happens. These usually have non-secretory light chain myeloma, where rapid kidney breakdown made them undetectable by older methods. However, With modern serum-free light chain assays, which are far more sensitive, these are now typically detectable. A huge diagnostic advance. IgD myeloma can also sometimes present mainly as light chain disease.
And the presence of light chains in the urine is common then, even with a serum M component. Does the type of light chain matter?
About two-thirds of patients with serum M components also have urinary light chains. Interestingly, the light chain isotype itself can impact disease behavior. It's not entirely clear why. Maybe genetics of cell proliferation or perhaps lambda light chains are just more likely to cause kidney damage and form amyloid than kappa light chains, a clinically relevant distinction.
And the heavy chain isotype matters for management too, right? Predicting complications based on the protein's properties.
Absolutely vital for predicting complications. For example, about half of patients with IgM paraproteins develop hyperviscosity syndrome because IgM molecules are large and tend to aggregate. Compare that to only 2 to 4% of patients with IgA and IgGM components. And among IgG myelomas, specifically the IgG3 subclass, has the highest tendency to form aggregates, leading to hyperviscosity or cold agglutination, sometimes even at lower concentrations. This level of detail is vital.
Now that we've mastered the foundation, let's zoom in on the most common and arguably best-known plasma cell disorder, multiple myeloma, or MM. How would you define it, and what are its unmistakable hallmarks?
Multiple myeloma represents a malignant proliferation of plasma cells, all from that single row clone. The disease impact stems from the tumor's expansion, its products like the M component, and the host's complex response. This leads to a number of debilitating organ dysfunctions. We often use the acronym CRAB to summarize the common end organ damage: hypercalcemia, renal insufficiency, anemia, and bone lesions.
CRAB, calcium, renal, anemia, bone.
Exactly. Bone pain, or direct consequence of those lesions, affects nearly 70% of patients. It's widespread and often painful.
The causes of cancer are often mysterious. What do we know about the etiology of myeloma? Specific risk factors or environmental links?
The precise cause isn't fully known, but we have some compelling clues. There's an increased frequency in populations exposed to nuclear radiation in World War II, with about a 20-year latency. Strong link there. It's also seen more commonly than expected among specific occupational groups: farmers, woodworkers, leather workers, those exposed to petroleum products. This suggests environmental links are at play.
Given the monoclonal nature from one cell, I imagine genetics play a significant role. What kind of chromosomal changes are typical?
You're absolutely right. Genetics are central. A variety of recurrent chromosomal alterations are consistently found. Roughly half of patients exhibit hyperdiploidy, meaning extra copies of specific chromosomes like 3, 5, 7, 9, 11, 15, 19, or 21, excess genetic material.
Half have extra chromosomes. What about the other half?
The other half often exhibit specific translocations involving the 14q32 chromosome, where pieces swap places with partners like T1114, T414, and T1416. Other frequent abnormalities include deletions on 13q14, amplification or deletion on 1q and 1p, and deletions on 17p13. These specific genetic changes are crucial. They influence aggressiveness, treatment response, and therapy choices.
So with all these different genetic changes, is there one clear genetic pathway to myeloma, a single smoking gun mutation, or is it more complex?
It's far more complex. Strong evidence suggests errors in switch recombination, the normal B-cell process to change antibody type participate early on, an initiating event. However, no single common molecular pathogenetic pathway has emerged. Genome sequencing hasn't found any single recurrent mutation above 20% frequency. NRAS, KRAS, and BRAF mutations are most common, over 40% combined, but still not universal.
So it's very heterogeneous.
Extremely. We often see complex clusters of subclonal variants at diagnosis, meaning different groups of myeloma cells in the same patient. And more mutations are acquired over time. This indicates a dynamic genomic evolution. The disease adapts, driving progression and treatment resistance. Interleukin-6, IL-6, may also be a crucial growth factor for many patients.
That genomic evolution concept is fascinating, the disease changing over time within a patient. Let's talk about how common this disease is and who it affects, epidemiology.
Myeloma remains a significant challenge. In 2021, about 34,920 new cases in the U.S., with over 12,000 deaths. Its incidence increases dramatically with age. Median age at diagnosis is 69, uncommon under 40.
Primarily older adults.
Yes. Males more commonly affected than females. And strikingly, individuals of Black ethnicity have nearly twice the incidence of whites, a significant health disparity. In 2018, myeloma accounted for 1.8% of all U.S. malignancies.
Are there broader global patterns? Does geography or ethnicity play a distinct role outside the U.S.?
Yes, distinct global patterns exist. Highest incidence in Black and Pacific Islander descent, intermediate in Europeans and North American whites, lowest in developing countries, including Asia. The higher incidence in developed countries might partly reflect longer life expectancy and more medical surveillance.
More diagnoses being made.
Potentially, other groups with higher incidence relative to U.S. whites include Native Hawaiians, female Hispanics, certain American Indian groups, and Alaska Natives. Chinese and Japanese populations generally have lower incidences. Interestingly, immunoproliferative small intestinal disease, IPSID, linked to alpha heavy chain disease, is most prevalent in the Mediterranean. Despite these regional differences, the overall characteristics, treatment response, and prognosis of myeloma are largely similar worldwide.
Let's connect this back to what the cells are doing. You mentioned cells expand and interact with their surroundings. How does the bone marrow microenvironment specifically contribute? This sounds critical.
This is where it gets profoundly interesting. Myeloma cells don't exist in isolation. They actively bind to bone marrow stromal cells, BMSCs, and the extracellular matrix via specific adhesion molecules. This binding isn't passive. It triggers signals promoting cell growth, survival, drug resistance, and migration within the marrow, essentially providing a protective niche.
A safe haven for the tumor.
Exactly. These effects are due to both direct cell-to-cell binding and the induction of various cytokines like IL-6, IGF-1, VEGF, and SDF1A, potent growth factors for myeloma cells.
And what are the downstream effects of these interactions? How do they translate into disease hallmarks?
Directly responsible for key aspects. Growth, drug resistance, migration are mediated through specific signaling cascades. RAS-RAF-MAP kinase, PI3K8, and protein kinase C pathways. Central to cell proliferation, survival, movement. Beyond stromal cells, other elements matter. Endothelial cells contribute to angiogenesis, new blood vessels feeding the tumor, and osteoclasts, absolutely vital for the characteristic bone destruction.
Right, the bone destruction.
Plus, immune cells like plasmacytoid dendritic cells, myeloid-derived suppressor cells, T helper 17 cells are often increased, actively supporting myeloma growth while normal anti-myeloma immunity is suppressed, creating a tumor-friendly ecosystem.
Speaking of osteoclasts, this brings us to the bone lesions, a major hallmark. What exactly is happening there, cellularly and molecularly?
Bone pain is the most common symptom, almost 70% of patients. Persistent localized pain often signifies impending fracture. The lesions are primarily analytic, meaning they destroy bone, leading to those characteristic punched-out lesions on X-rays. This destruction is caused by tumor cell proliferation, activating osteoclasts, the cells that normally break down bone.
They ramp up the bone breakdown.
Exactly. Myeloma cells produce potent osteoclast activating factors, OAFs, including cytokines like IL-1, lymphotoxin VEGF, and rank ligand, driving this activity, creating a profound imbalance in bone remodeling.
So it's not just bone destruction, but also a striking lack of new bone formation. That sounds incredibly fragile.
Exactly, a devastating double blow. Myeloma cells also actively suppress osteoblasts, the bone-forming cells, by producing DKOF1 or DKK1. This is why radioisotopic bone scans detecting new bone formation are less useful than X-rays, which show bone loss. This lysis mobilizes calcium from bone into the blood,
leading to hypercalcemia.
Yes, and serious complications like lethargy, weakness, confusion. Localized lesions can cause vertebral collapse, leading to excruciating spinal cord compression, a true emergency.
Another major problem is susceptibility to bacterial infections. Why are myeloma patients so vulnerable?
A profound issue. Recurrent infections are a presenting feature in about 25% of patients, and over 75% experience a serious infection sometime. Most common are pneumonias and pyelonephritis, often from common bacteria like strep pneumo, Staph aureus, Klebsiella, E. coli. The vulnerability is complex.
What are the specific contributing causes? It sounds like more than just low antibody production.
You're right, it's systemic immune dysfunction. First, diffuse hypogammaglobulinemia, a generalized decrease in normal antibodies, even excluding the M component, due to both decreased production and increased destruction. The large M component speeds breakdown of normal antibodies. Second, some patients develop regulatory cells suppressing normal antibody synthesis, leading to poor responses, especially to bacterial capsule antigens. Third, various T-cell abnormalities. Decreased T helper 1, increased T helper 17, pro-inflammatory, aberrant T regulatory function, plus impaired granulocyte function, complement abnormalities.
A multi-pronged attack on immunity.
Yes. And therapies like dexamethasone further suppress immunity. Newer ones like BCMA CAR-T cause prolonged hypogammaglobulinemia, while bortezomib predisposes to shingles. A very compromised system.
That's a complex picture. Now, the kidneys, renal insufficiency is part of CITRAB. How does myeloma affect them?
Renal pathology is noted in over 50% of patients. Hypercalcemia is the most common cause of renal failure. Other factors include glomerular amyloid deposits, hyperuricemia, recurrent infections, frequent NSAID use, contrast dye, bisphosphonates, and occasionally direct kidney infiltration by myeloma cells.
But there's a specific damage related to the light chains, right? Myeloma kidney.
Yes, absolutely. Tubular damage from light chain excretion is almost always present, a hallmark. Normally, light chains are filtered, reabsorbed in tubules, and broken down. With a massive increase, tubular cells get overloaded. Direct damage from light chains or release of intracellular enzymes. The earliest sign can be adult Fanconi syndrome, proximal renal tubular acidosis, losing glucose, amino acids, trouble acidifying urine.
So the proteinuria is mostly light chains, not albumin. And what about unusual chemistry changes like a decreased anion gap?
Correct. Proteinuria isn't usually with hypertension, and it's nearly all light chains because glomerular function is typically normal. Albuminuria only if glomeruli are involved, like with amyloid. Another interesting finding is a decreased anion gap, Na+, Cl plus HCO3M, because the M component is cationic, leading to chloride retention, often with pseudohyponatremia, artificial low sodium, because high protein means less water per serum volume.
Pseudohyponatremia, okay.
The good news, renal dysfunction from light chains or amyloid can be partially reversible with effective therapy if caught early. But patients are highly susceptible to acute renal failure if dehydrated. Fluid management is paramount.
Moving to blood, what are the characteristic hematologic abnormalities? Anemia is very common.
Normocytic normochromic anemia occurs in about 80% of patients, contributes significantly to fatigue, usually due to multiple factors. Tumor replacing marrow, tumor factors inhibiting blood formation, reduced kidney erythropoietin, effects of therapy. Mild hemolysis can also contribute. A larger than expected fraction might also develop megaloblastic anemia from folate or B12 deficiency. Granulocytopenia and thrombocytopenia are rare at diagnosis, usually therapy-induced.
And what about clotting issues, bleeding or clotting risks?
Clotting abnormalities can occur, bleeding due to antibody-coated platelets not working, M component interfering with clotting factors, RPP2V78, antibodies to clotting factors, or amyloid damage to blood vessels. Conversely, deep venous thrombosis, DVT, is frequently observed, especially with immunomodulatory drugs like thalidomide, lenalidomide, pomalidomide, particularly with dexamethasone, requires prophylactic anticoagulation.
And I've heard of hyperviscosity syndrome. How does that fit in?
Raynaud's phenomenon in impaired circulation can result if the M component forms cryoglobulins, precipitating in the cold. Hyperviscosity syndromes depend on the M component's properties, most common with IgM, IgG3, and IgA. Due to size or aggregation tendency, defined based on serum viscosity relative to water, normal is 1.8. Symptoms like headache, fatigue, shortness of breath, visual changes typically occur above 4 centipoises, usually reached around 40 GL for IgM, 50 GL for IgG3, 70 GL for IgA, but can occur at lower levels depending on the specific protein. That directly affects blood flow, leading to symptoms. What about neurological symptoms beyond cord impression? Although overt neurosymptoms occur in a minority, they have many causes. Hypercalcemia causes lethargy, weakness, depression, confusion. Hyperviscosity leads to headaches, fatigue, shortness of breath, worsening heart failure, visual issues, ataxia, vertigo, retinopathy, somnolence, even coma, all due to impaired brain blood flow. And bony damage, especially vertebral collapse, causes cord compression, radicular pain, loss of bowel bladder control, a neurological emergency.
Is there also direct nerve involvement beyond compression?
Yes. Peripheral nerve infiltration by amyloid can cause carpal tunnel syndrome and other sensorimotor neuropathies. Neuropathy with MGUS and myeloma is more often sensory than motor, associated more with IgM. In over half of these neuropathy patients, the IgM targets myelin-associated globulin, MAG, explaining the demyelination.
It's curious how a disease starting in bone marrow often stays mainly there. Why not often cause large spleen or lymph nodes?
A very astute observation. Despite widespread distribution of normal plasma cells, tumor expansion in myeloma is overwhelmingly within bone and marrow. For reasons not fully understood, it rarely causes significant spleen, lymph node, or gut lymphatic tissue enlargement. Makes those lytic bone lesions very distinct.
So summing up the symptoms, any immediate emergencies clinicians must watch for?
Yes, absolutely. Several critical emergencies demand urgent intervention. Pathologic fractures, severe hyperviscosity, overwhelming sepsis, and severe hypercalcemia. Rapid diagnosis and management are paramount.
Given all these varied symptoms and M component types, how is multiple myeloma definitively diagnosed? And how do clinicians assess its severity? This requires precision.
Diagnosis of active symptomatic myeloma needs three key criteria. First, bone marrow plasmacytosis over 10%. Second, presence of serum and/or urine M component. And third, critically, at least one myeloma-defining event, detailed in Table 111.1. These signify active disease or high tumor burden needing therapy. The marrow plasma cells are typically CD138+ and show monoclonal kappa or lambda light chains, confirming their clonal origin.
What are the most important conditions to distinguish myeloma from? Sounds like common pre-myeloma states need careful differentiation.
You've hit a crucial point. The most important differentials are monoclonal gammopathy of undetermined significance, MGUS, and smoldering multiple myeloma, SMM. These are vastly more common than active myeloma. Differentiating them is paramount because treatment approaches are fundamentally different.
Let's break those down. What exactly is MGUS and how common is it?
MGUS is surprisingly prevalent, about 1% of the population over 50, rising to 10% over 75. Quite common. Diagnostic criteria: serum monoclonal protein, non-IgM type, less than 30 GL, and clonal bone marrow plasma cells less than 10%. Crucially, absence of any myeloma-defining events or related amyloidosis, essentially a benign, asymptomatic state.
Very common, but thankfully doesn't always progress. What are the chances and what indicates higher risk?
No, thankfully not all progress. Risk of progression from MGUS to myeloma or related disorder is about 1% per year. All myeloma is thought to be preceded by MGUS, even if undiagnosed. Higher progression risk is strongly associated with three factors: non-IgG subtype, IgA or IgD, abnormal kappa lambda free light chain ratio, and serum M protein over 15 GL.
Those three factors are key.
Right. If a patient has none, only a 5% chance of progression over 20 years. If all three are present, it predicts a substantial 60% chance over 20 years. Critical for monitoring.
What about smoldering multiple myeloma, SMM, its characteristics? How does it fit between MGUS and active myeloma?
SMM is essentially more advanced than MGUS, higher disease burden but still asymptomatic. Two criteria must be met: serum monoclonal protein, IgD or IgA, 30 GL, or R urinary monoclonal protein over 500 mg 24Hers, and/or clonal bone marrow plasma cells between 10% and 60%. Again, critically, absence of any myeloma-defining events or amyloidosis. Significant clonal expansion, but without overt organ damage yet.
And what indicates higher progression risk for SMM? Who needs closer monitoring or maybe early intervention?
Features for higher SMM progression risk are similar to high-risk MGUS, but higher thresholds: bone marrow plasmacytosis 10%, abnormal kappa lambda ratio, and serum M protein 30 GL. Patients with only one have a 25% chance of progression in 5 years. Those with high-risk SML, all three features, face a 76% chance in 5 years. This risk stratification allows careful monitoring and consideration for early intervention in some very high-risk cases.
You mentioned myeloma-defining events earlier as key for active disease. Can you elaborate? What truly signals active disease needing treatment beyond stabber?
These are critical indicators of overt end organ damage or high tumor burden, definitively signaling active disease requiring treatment. The CRAB features are primary indicators: hypercalcemia, renal insufficiency, anemia, one or more lytic bone lesions. But beyond CRAB, specific biomarkers of malignancy also qualify, even without the CRAB symptoms. These include clonal bone marrow plasma cell percentage, 60%, very high burden, and uninvolved serum-free light chain ratio, 100, involved must be 100 milligl, indicating massive light chain production, or more than one focal lesion on MRI, 5 millimeter, showing localized marrow infiltration. These biomarkers identify patients at imminent risk, allowing proactive intervention.
Sounds very precise. What about other more localized variants like solitary lesions?
Two important variants: solitary bone plasmacytoma and solitary extramedullary plasmacytoma. Single lesions, bone or soft tissue, with clonal plasma cells. Crucially, normal bone marrow outside lesion, no systemic myeloma-defining events. Often affect younger individuals. Less than one-third have a detectable M component, highly responsive to local radiation therapy, around 40 GI. If M component was present, it should disappear after treatment.
And their long-term outlook.
Solitary bone plasmacytomas may recur elsewhere or evolve into myeloma. Extramedullary plasmacytomas rarely recur or progress, suggesting a more benign biology sometimes.
That distinction is key. Let's talk about the full diagnostic workup. What extensive tests are done to confirm and characterize the disease?
A comprehensive workup, as outlined in Table 111.2, is essential. To evaluate clonal plasma cells, bone marrow aspirate and biopsy are essential. Histology clonality assessment by kappa lambda immunostaining via flow cytometry or IHC. If plasmacytoma is suspected, fine needle aspiration or core biopsy. Plasma cell percentage preferably from core biopsy. To evaluate clonal paraprotein, serum protein electrophoresis and immunofixation, crucial for detection characterization. Quantitative serum immunoglobulins, IgG, IgA, IgM, to check suppression. 24-hour urine for Benz-Jones protein quantification. Serum-free light chain and ratio, essential sensitive marker. Maybe IgD-IgE, immunofixation. Note: dipsticks unreliable for light chains, old heat test often false negative. To evaluate end organ damage. Hemogram for anemia, chemistry panel for renal function, calcium, skeletal survey x-rays for letter lesions, PET-CT or MRI increasingly used for detailed marrow infiltration, cord compression, extramedullary disease. PET-CT valuable for smoldering versus active confirming solitary plasmacytoma, evaluating response in non-secretory myeloma. Serum alkaline phosphatase, usually normal due to lack of osteoblastic activity.
Truly thorough. How do all these findings lead to prognosis and staging? How do clinicians predict outlook and guide treatment?
For prognosis, a key marker is serum beta-2 microglobulin. The single most powerful predictor of survival can substitute for staging. It's the light chain of class I MHC antigens. The combination of serum beta-2 microglobulin and albumin levels forms the basis for the three-stage International Staging System, ISS, shown in Table 111.3. The older Dury-Salmon system is now largely obsolete.
But there's a revised ISS, isn't there? What makes it revised and more powerful? Incorporating genetics.
Yes, precisely. The Revised International Staging System, or ISS, is now most widely used, prognostically superior. It incorporates the ISS stage with crucial cytogenetic changes detected by FIs from marrow. These include high-risk genetics like 17p deletion, translocations T4, 14, 16, T14, 20, plus 1q amplification and hyperdiploidy. Known high-risk features. Interestingly, 13q deletion, previously poor prognosis, isn't considered so with newer agents. Shows how treatment changes prognostic relevance. Other high-risk factors: high labeling index, circulating plasma cells, poor performance status, elevated LDH.
And the very latest from genomic sequencing. How's that impacting prognosis and personalized treatment?
Genomic sequencing revolutionized our understanding. Deep characterization of genes, pathways, clonal heterogeneity. Myeloma has a very heterogeneous mutational landscape. 58 mutations per transcribed genome, 7,000 in whole genome. No single unifying mutation, most frequent. KRAS and RAS, 20% each, followed by TB53, DIS3, FAM46C, BRA, 5-10%, all others 5%. These results are now being applied to develop new, targeted, personalized therapies. Moving closer to precision medicine. #, prognosis.
So with all these advances, what's the overall prognosis for myeloma today? Significantly improved.
Progress has been remarkable. Median overall survival is now over 8 years. Subsets of younger patients are surviving more than 10 years, almost unimaginable decades ago. A profound improvement.
Incredibly encouraging. What are the major causes of death today? Always myeloma itself or other factors?
While progressive myeloma is primary, causes are often multifactorial. Key causes: unrelenting myeloma, renal failure, sepsis, immune compromise, therapy-related myelodysplasia, rare but serious. However, nearly a quarter now die from intercurrent illnesses, more related to age and comorbidities than the tumor itself. Things like heart attack, lung disease, diabetes, stroke. Highlights need for comprehensive supportive care.
This is where the rubber meets the road treatment. What are the general philosophies? Let's start with pre-myeloma states. MGUS, SMM, and solitary plasmacytoma.
For MGUS, no specific intervention is usually indicated. Risk of progression is low. Treatment risks outweigh benefits. Follow-up yearly or less except for higher risk MGUS. Check SPEP, CBC, creatinine, calcium every 6 months.
Are there exceptions for MGUS where therapy might be considered?
Rare exceptions. If MGUS patient develops severe polyneuropathy with no other cause, therapy targeting the M protein might be considered. Plasmapheresis, maybe rituximab for IgM, myeloma-like therapy for IgA. If renal dysfunction develops due to the monoclonal antibody, like light chain deposition, no consensus, but lowering M protein with agents like bortezomib has been advocated, still debated.
What about smoldering multiple myeloma, SMM? Treated immediately or observed?
Generally watchful waiting for lower risk SMM. About 10% have indolent course, slow progression over years. Observation often appropriate initially. High-risk SMM is an evolving area. Early intervention, the nalodimide dexamethasone, shows promise in delaying progression but still being refined. Currently, anti-tumor therapy for SMM usually starts only when myeloma-defining events occur.
And the solitary plasmacytomas. How are these localized lesions managed?
Patients with solitary bone or extramedullary plasmacytomas can expect prolonged disease-free survival after local radiation, around 40G. Highly sensitive. If M component present, should disappear after treatment. If occult marrow involvement occurs in solitary bone plasmacytoma, slow fall or return of M component, patients usually respond well to systemic therapy, indicating progression.
Now, for symptomatic multiple myeloma, what are the overall goals, beyond just prolonging life?
For symptomatic MM, intervention is always required immediately. Multi-pronged attack. Two primary goals: systemic therapy to control myeloma, deepest, most durable remissions, and comprehensive supportive care. Manage symptoms, complications, therapy side effects. Combined treatments significantly prolong survival and vastly improve quality of life.
The treatment algorithm in Figure 111.6 looks involved. Can you walk us through the general flow for newly diagnosed patients?
Yes, general flow often starts with intensive induction therapy, rapidly reduced tumor, followed by consolidation, often high-dose therapy, autologous stem cell transplants if eligible, and or maintenance therapy, deep and prolonged remission. Then management of relapse if it occurs. Therapy choice depends on patient age, performance status, comorbidities, influencing ability to tolerate intensive treatments like transplant, highly individualized.
What are the major classes of agents used, especially for newly diagnosed MM? Seems like an explosion of new drugs.
A revolution over the last 2 decades. 3 profoundly important classes approved for newly diagnosed MM, often in combination. Immunomodulatory agents, IMIDs, thalidomide, lenalidomide, pomalidomide, modulate immune system direct anti-myeloma effects, proteasome inhibitors, PIs, bortezomib, carfilzomib, ixazomib, block proteasome, toxic proteins build up, kill cancer cells, and targeted antibodies, daratumumab, elotuzumab, belantamab mafodotin, target proteins on myeloma cells, flag for destruction, or deliver toxin.
Let's talk about induction therapy. How have combinations changed outcomes?
Transformative impact. Past, thalidomide dexamethasone, 23 response, then lenalidomide or bortezomib with dexamethasone, 80% response, better toxicity, preferred induction. Now, 3 drug regimens are standard for transplant eligible. Lenalidomide plus PI, bortezomib or carfilzomib plus dexamethasone achieves nearly 100% response, 30% complete remission, CR, preferred globally. Other combos, bortezomib thalidomide, bortezomib cyclophosphamide, also 90% response. Addition of fourth agent like daratumumab, anti-CD38, giving even deeper responses, typically 4-6 cycles before considering transplant.
What about patients not candidates for transplantation, induction for them?
For those not transplant candidates, age 70, cardiopulmonary issues, comorbidities, same 2 or 3 drug combos are standard. Dose schedules modified based on age frailty. Example: modified lenalidomide, bortezomib, dexamethasone, RVD light, high response 86%, CR 32% with reduced toxicity, intermittent melphalan-prednisone, MP, also combined with novel agents. Thalidomide MPT, better than MP alone for 65, or divelumab MP, also superior to MP alone. Continuous lenalidomide dexamethasone seems superior to MPT. Its combination with daratumumab gives even higher response, 92.9%, CR, 46.7%, improved survival. Standard for older adults.
Let's discuss high-dose therapy and autologous stem cell transplantation, a major step. How does it work?
HDT with ASCT and subsequent consolidation maintenance are standard for most eligible patients. Cornerstone of modern treatment, crucial. Avoid alkylating agents like melphalan before stem cell collection, damage to stem cells. If on lenalidomide, collect within 6 months. Continued use impairs collection. Process, collect patient stem cells, give high-dose chemo, reinfuse stem cells to rescue marrow.
What have randomized studies shown about HDT benefits versus standard therapy?
Randomized studies consistently show HDT achieves significantly higher overall response, additional 25-40% achieve CR, significantly prolonged progression-free and overall survival, true game changer. However, very few benefit from a second transplant unless first one failed to achieve CRV-GPR, rare. Max benefit usually from initial transplant.
So timing of transplantation is also a factor. Immediately after induction or flexibility?
Great question. Evolving area. Interestingly, a large randomized study showed no significant overall survival difference between early transplant versus delayed transplant at relapse. Provides valuable flexibility. Option to delay, especially with effective newer agents. Allogeneic transplant, donor cells, has high response but significant toxicity, GVHD. Non-myeloablative NLAO reduces toxicity but generally only in clinical trials. Aims for graft versus myeloma effect.
What about maintenance therapy after intensive treatments? Always necessary.
Maintenance is crucial for prolonging remissions after standard dose or HDT. 2 phase 3 studies showed improved progression-free survival, PFS. One showed overall survival, OS benefit with lenalidomide maintenance after HDT versus placebo. Compelling evidence. In non-transplant candidates, 2 other phase 3 studies showed prolonged PFS with lenalidomide maintenance after various inductions.
Any concern about long-term maintenance? Continuous drug exposure?
Concern about small increased risk of second primary malignancies, myeloid, with lenalidomide maintenance. However, multiple studies expert consensus. Benefits in reducing progressive disease death from myeloma far outweigh the small risk. Favorable risk-benefit for most. For high-risk cytogenetics, combinations like lenalidomide-bortezomib or oral PI ixazomib showing promise as maintenance combo post-transplant. Deeper control.
What happens when the disease relapses? How is relapse disease approached?
Relapse myeloma is challenging but increasingly manageable. Wide array of agents, often different combos than induction. Can reuse lenalidomide-bortezomib if prior response was good prolonged. Second-gen PI carfilzomib and pomalidomide show robust efficacy even in relapsed refractory resistant to Lenbort. Oral PI ixazomib plus lenalidomide dexamethasone offers convenient all-oral regimen.
Are there new targeted antibodies making a difference in relapse?
Yes, antibodies are powerful additions. 3 approved for relapsed daratumumab, anti-CD38, high response improved PFS alone, better when added to bortezomib dex or lenalidomide dex. Subcutaneous form available, less toxicity, convenient. Isatuximab, another anti-CD38, also high response improved PFS with pomalidomide or carfilzomib plus dex. Elotuzumab, anti-SLAMF7, significant activity with lenalidomide dex in relapsed refractory, but not alone.
And truly novel mechanisms attacking cancer in new ways.
Field continues to innovate. Panobinostat, HDAC inhibitor, plus bortezomib dex approved for relapsed refractory, superior response PFS versus bordex alone. Alters gene expression. 2 newer agents with unique mechanisms. Selinexor, export inhibitor, blocks protein export from nucleus. Melflufen, alkylator conjugated to peptide for targeted delivery to myeloma cells expressing aminopeptidase. Both approved for relapsed refractory. Expanding options.
What about cellular therapies like CAR T cells, cutting-edge area? How does it apply to myeloma?
Tremendously exciting area. Major focus. Targeting BCMA, B-cell maturation antigen, almost exclusively on plasma myeloma cells, ideal target. Belantamab mafodotin, anti-BCMA antibody drug conjugate, delivers toxin or statin to tumor cells. Responses in relapse refractory. Unique eye toxicity needs close monitoring. Cellular therapy. ID-Cabdagene Viclucel, ID-cell. Revolutionary CAR T targeting BCMA, approved 4th line. In advanced patients, median 6 prior lines, 73% responded, 33% CR. Profound efficacy.
Amazing response rates. What are the downsides?
Primary toxicities, cytokine release syndrome, CRS, and neurotoxicity. Require close monitoring, aggressive management by specialized centers. BCMA is target for many investigational agents. Other CRTs, bispecific antibodies link anti-BCMA plus anti-CD3 to guide T cells. Incorporation of these agents improving survival quality of life. Unprecedented hope.
With all these options, how do doctors track response, especially with different M component half-lives?
Critical question. Nuanced approach needed. Serum M component improvement can lag symptoms, long half-life 3 weeks. Fall depends on tumor kill rate and protein catabolism rate. Serum immune light chains have shorter half-life, 6 hours. Levels fall quicker. Excellent early indicators. But urine levels influenced by kidney function, less reliable measure if renal dysfunction exists. Often look at composite markers.
And what's the ultimate goal today? Always complete remission.
Historically, complete remission, CR, disappearance of M protein, normal marrow by microscopy was standard goal. Now move beyond that. New techniques. High-res sequencing or multicolor flow cytometry for minimal residual disease, MRD, in marrow. Important new endpoints. Measures 1 myeloma cell in a million. Unparalleled sensitivity. Absence of MRD predicts longer PFS and OS. Critical benchmark. While not all achieve CR, even partial responses can last long periods, clinically meaningful. Deeper response equal better outcome.
Beyond systemic therapies, supportive care seems equally important in myeloma. What are key elements to optimize well-being?
Supportive care is absolutely critical, often as important as primary anti-tumor therapy. Comprehensive approach. Anticipate managed disease complications and treatment side effects. Optimizing overall health quality of life.
Let's start with prophylaxis for treatment side effects. How prevents issues from potent drugs?
Patient safety paramount. If using bortezomib, herpes zoster prophylaxis, antiviral for shingles, is routine. Bortezomib neuropathy lessened by subcutaneous admin and weekly schedule. Lenalidomide requires DVT prophylaxis, aspirin or stronger anticoagulants for high risk due to clotting risk. Anti-BCMA CAR-T patients may need IV gamma globulin supplementation due to prolonged hypogamma-globulinemia, prevents infections.
And disease-related complications. How is dangerous hypercalcemia managed?
Hypercalcemia responds well to multimodal approach. 4-V bisphosphonates inhibit bone breakdown. Glucocorticoids, aggressive IV hydration, natriuresis, increase sodium-calcium excretion, rarely calcitonin for rapid reduction. Bisphosphonates like pamidronate or zoledronate typically monthly for 1-2 years, then every 2-3 months. Reduce bone resorption, preserve performance status quo, decrease bone complications, maybe anti-tumor effects. Minority experience osteonecrosis of jaw, ONJ, or renal dysfunction. Need careful monitoring. Denosumab, RANKL inhibitor, is subcutaneous alternative, similar effects preventing bone complications.
Other ways to strengthen bones or address painful lesions.
Treatments like fluorides, calcium, vitamin D, androgens, suggested but not proven effective as primary intervention. For severe pain from vertebral compression fractures, kyphoplasty or vertebroplasty, inject bone cement, considered for rapid pain relief mobility. Most localized bone lesions respond to analgesics and primary anti-tumor therapy. Certain painful lesions may respond more promptly to localized radiation. For renal failure, proactive measures key. Avoiding dehydration paramount enhances light chain calcium excretion. Acute renal failure, plasmapheresis, 10x more effective clearing light chains than peritoneal dialysis. Swift temporary relief. Role in reversing established failure controversial. Most important, reduce protein load via effective anti-tumor therapy, SPI bortezomib, can improve renal function in 50%. Lenalidomide usable but needs dose modification, renally excreted. Watch for treat UTIs early.
What about hyperviscosity?
Plasmapheresis is acute treatment of choice for severe hyperviscosity. Rapidly removes large proteins, quick symptomatic relief, critical emergency intervention.
And managing infections given the immune compromise.
Constant serious concern. Pneumococcus dreaded. Polysaccharide vaccines may not elicit a strong response. Conjugate vaccines generally more protective recommended. Prophylactic 4-V gamma globulin, IVIG, used for recurrent serious infections or severe hypogammaglobulinemia. Chronic oral antibiotics not generally warranted. Resistance, microbiome disruption, infection prevention, education, prompt treatment critical.
Finally, neurological issues and bone pain.
New worsening neurosymptoms in legs, severe localized back pain, bowel bladder issues need emergency MRI spine, check cord compression. If confirmed, urgent local radiation plus high-dose glucocorticoids. If deficit increasing substantial, emergent surgical decompression may be needed. Most bone lesions respond to analgesics plus systemic therapy. Persistent painful lesions may respond quicker to localized radiation. Anemia may respond to EPO plus hematinics, iron, folate, B12, establish specific cause for targeted therapy.
Let's shift to another significant plasma cell disorder, Waldenström's macroglobulinemia, WM. How does it differ from myeloma beyond the M component type?
WM, first described 1948, is a malignancy of lymphoplasmacytoid cells secreting IgM, large antibody. Unlike myeloma, characterized by a lymphadenopathy, hepatosplenomegaly, widespread lymphoid involvement, major clinical manifestation often hyperviscosity syndrome due to large IgM protein thickening blood. Shares features with CLL, myeloma, lymphocytic lymphoma, mixed features. Originates from post-germinal center B-cell, IgM-bearing memory B-cell characteristics.
So distinct from IgM myeloma, even though both involve IgM, how differentiated?
Yes, very distinct. Critical for management. While WM and IgM myeloma share symptoms due to IgM, pathophysiology therapy differ. IgM myeloma diagnosis usually reserved for patients with lytic bone lesions, WM typically lacks, predominant CD138 plus plasma cells in marrow. Higher fracture risk than IgM myeloma versus WM. Key difference.
Are there specific genetic insights into WM, like for MM?
Absolutely. Major breakthrough. Familial occurrence common, molecular basis unclear, but distinct MYD88L265P somatic mutation present in 90% WM patients and most IgM-MGUS. Highly specific molecular marker. Other common mutations: CXCR4, 30-40%, ARID1A as adnexstem, 17%, CD79B, 8-15%, MYD88 status now used diagnostically to discriminate WM from marginal zone lymphomas, IgM myeloma, CLL.
How does that MYD88 mutation influence the disease? What pathway is activated?
MYD88L265P mutation explains pathogenesis via toll-like receptor, TLR, and IL-1 receptor signaling. Leads to constitutive activation of IRAK4 and DRAG1, then NFT activation, critical for survival, proliferation, inflammation. CXCR4 mutations induce ectrica-12 signaling, can lead to drug resistance, SP2BTK inhibitors, via its ligand CXCL12. Understanding these pathways allows targeted therapy.
And the epidemiology of WM is similar to myeloma.
Like myeloma, slightly more common in men, incidence increases with age, median age diagnosis 64. Shares general demographic profile, primarily older adults.
You mentioned peripheral neuropathy earlier in myeloma, specific strong connection in WM, related to IgM.
Yes, very specific connection. IgM in some WM patients targets myelin-associated glycoprotein, MA, crucial for nerve insulation. Demyelinating disease similar to MS. About half of WM patients with peripheral neuropathy test positive for anti-MAG antibody, autoimmune attack on nerve sheaths. Neuropathy can even precede neoplasm diagnosis, sometimes starts after viral infection, cross-reactivity, an intriguing autoimmune component.
So how does the clinical picture of WM truly differ from myeloma, WM red flags?
While both involve marrow, crucial difference. WM does not cause litholytic bone lesions or hypercalcemia, major differentiator. WM marrow shows 10% infiltration with lymphoplasmacytic cells. Specific markers, IgM plus M, CD19 plus EV, CD20 plus EVs, rarely CD5 plus EVs, CD10, CD23M, increased mast cells, IgM opponent present, often 30 GL. But large size means little renal excretion, only 20% excrete light chains, renal disease uncommon, contrast to myeloma. Light chain usually kappa, 80%. Presence with weakness, fatigue, recurrent infections like myeloma, but hallmark WM symptoms due to hyperviscosity. Epistaxis, visual disturbances, neurosymptoms, neuropathy, dizziness, headache, transient paresis. NYD80 ACXCR4 mutations affect presentation. CXCR4 linked to higher marrow burden, hyperviscosity. Wild type NYD88 linked to lower marrow burden.
What physical signs? Examination findings.
Often distinct generalized adenopathy, hepatosplenomegaly, less common in typical myeloma. Ophthalmoscope may show vascular segmentation, dilation of retinal veins, direct signs of hyperviscosity, often normocytic anemia, but rouleau formation, RBC stacking, and positive Coombs test, autoimmune hemolysis, much more common than myeloma. Malignant lymphocytes usually in peripheral blood, about 10% macroglobulins or cryoglobulins precipitating cold, pure M components, cause Raynaud's vascular symptoms. Important for sample collection, draw blood into warm syringe, deliver warm to lab.
When is treatment initiated for WM? Only when symptomatic?
WM diagnosis, lymphoplasmacytic infiltrate any level, plus IgM paraprotein, any size. But treatment typically not initiated unless symptomatic or signs of impending organ damage, like increasing anemia, hyperviscosity signs, progressing lymphadenopathy, hepatosplenomegaly, causing issues. Serious hyperviscosity symptoms, altered consciousness, paresis, can be controlled acutely rapidly by plasmapheresis, removes IgM quickly.
Typical prognosis for WM factors influencing it.
Median survival, 50 months. But many have indolent disease, don't need therapy for years. Prognosis based on pretreatment factors. Older age, male, systemic symptoms, cytopenias, define high risk. NYD88CXCR4 status, increasingly important for prognosed treatment selection.
First-line treatment options for symptomatic WMM, BTK inhibitors seem key.
You're right, BTK inhibitors revolutionized WM. First line often includes BTK inhibitors, ibrutinib, alkylators, bendamustine, cyclophosphamide, PIs, bortezomib, carfilzomib, ixazomib, alone or, more frequently, with rituximab, anti-CD20. Ibrutinib targets activated BTK, driven by MYD88. In one prior line therapy, overall response 91%. Best responses in mutated MYD88 wild-type CXCR4. Delayed lower response if mutated CXCR4 resistance. Still usable if wild-type MYD88, but lower response. Choice depends on genomics, drug availability, patient profile. Special consideration. Rituximab can cause IgM flare. Temporary increase worsen hyperviscosity. So plasmapheresis before rituximab, or withhold initially if very high IgM. Fludarabine, cladribine, also highly effective single agents.
What's on the horizon for WM treatment?
Future exceptionally promising. With MYD88 pathway known, novel BTK inhibitors, acalabrutinib, zanubrutinib, tirabrutinib, developed approved, better safety efficacy. Inhibitors targeting IRK14 downstream of MYD88, BCL2 antagonist venetoclax explored in trials, more targeted approaches. HD-chestic use declined significantly due to availability of these highly effective, less toxic novel agents. Durable remissions with more tolerable treatments. Hashtag POEMS syndrome.
Next up is POEMS syndrome. Sounds like a specific set of symptoms coming together.
That's right. POEMS is a fascinating, distinct perineoplastic syndrome linked to plasma cell disorder. Acronym captures defining features: polyneuropathy, organomegaly, endocrinopathy, M protein, skin changes. Diagnosis needs specific criteria. Table 1.11.1, usually O2 Moser plus O1 minor, multisystemic nature.
Let's break that down. Polyneuropathy presentation, linked to specific bone lesions.
Usually severe progressive sensoromotor polyneuropathy, sensation plus motor, often disabling. While neuropathy in 1.4% myelomas, POEMS is rare subset. Crucially, almost always associated with distinct sclerotic bone lesions, increased density, unlike cactolytic lesions in typical myeloma. Key diagnostic clue.
An organ enlargement, the Oh, what organs differs from typical myeloma?
Unlike typical myeloma, organomegaly rare, in poems, hepatomegaly, enlarged liver, lymphadenopathy, enlarged nodes occur in 23 patients. Splenomegaly, enlarged spleen, in 13. Lymphadenopathy often resembles Castleman's disease, linked to IL-6 overproduction, suggesting cytokine-driven pathology key driver.
Endocrine manifestations, the E, very unique for plasma cell disorder.
Diverse endocrine effects highlights broad systemic impact. Amenorrhea, women, impotence senocabancia, men, gonadal dysfunction, hyperprolactinemia, loss of hypothalamic control, maybe with papilledema, elevated CSF pressure protein, type 2 diabetes in 13, hypothyroidism, adrenal insufficiency occasionally noted, widespread endocrine disruption.
And skin changes, the S, distinctive.
Skin changes varied, often distinctive clues. Diffuse hyperpigmentation, hypertrichosis, excess hair, skin thickening, digital clubbing. Other manifestations beyond acronym: peripheral edema, often severe ascites, pleural effusions, fever, thrombocytosis, high platelets. Not all components may be present initially, needs high index of suspicion.
Pathogenesis, why this unusual constellation? Unifying mechanism.
Into pathogenesis, unclear, but strong evidence points to profound cytokine dysregulation as central mechanism. High circulating pro-inflammatory cytokines, IL-1, IL-6, VEGF, linked to organomegaly, TNF consistently documented. Inhibitory cytokine, TGF-beta, often lower than expected. Significant imbalance favoring inflammation, angiogenesis, cell growth. Explains complex picture.
How is POEMS treated? Similar to myeloma. Unique considerations.
Generally treated similarly to typical myeloma. Target underlying plasma cell disorder. Note: plasmapheresis doesn't appear beneficial in POEMS, unlike WM hyperviscosity. Patients with isolated sclerotic lesions causing symptoms. Neuropathic symptoms may resolve after local radiotherapy for plasmacytoma. Similar to MM, novel agents, IMIDs, PIs, HT-TSET pursued in selected patients associated with prolonged PFS, shows effectiveness of anti-plasma cell therapy. Choice depends on systemic involvement patient fitness.
Finally, let's turn to an even rarer group. The heavy chain diseases. What makes them distinct and aberrant?
Heavy chain diseases are rare lymphoplasmacytic malignancies. Unique characteristic: absence of light chains, secrete only defective heavy chain, usually intact Fc fragment, deletion in FeV region, needed for complete antibody. Gamma, alpha, Mo heavy chain disease described, corresponding heavy chain type. No delta or epsilon reported. Molecular analysis revealed structural genetic defects accounting for aberrant chain.
Let's start with gamma heavy chain disease, Franklin's disease. Unique clinical features.
Affects wide age range countries. Symptoms: lymphadenopathy, fever, anemia, malaise, hepatosplenomegaly, weakness, often associated with autoimmune diseases, isthmus rheumatoid arthritis. Most distinctive symptom: palatal edema, infiltration of Waldeyer's ring, back of throat lymphoid tissue. Quite specific, anomalous serum M component, often 20 GL, reacts with anti-IgG but not anti-light chain regions, confirms absence. Present in serum marine, usually gamma-1 subclass, may have thrombocytopenia, eosinophilia, non-diagnostic marrow, increased lymphocytes, plasma cells, don't stain for light chain.
Prognosis and treatment for this one.
Historically rapid downhill course, often die of infection, immune suppression. Some survive up to 5 years with chemo. Therapy indicated when symptomatic. Chemo combos used for low-grade lymphoma, shares features. Rituximab also reported effective.
What about alpha heavy chain disease, Seligman's disease? Affects specific body part.
Actually the most common heavy chain disease, closely related to Mediterranean lymphoma, affects young people where intestinal parasites common in Mediterranean, Asia, South America, suggests environmental infectious trigger, defined by infiltration of small intestine lamina propria with lymphoplasmacytoid cells secreting truncated alpha chains.
Easy to detect these alpha chains. Diagnostic challenges.
Can be challenging.
Okay.
Tend to polymerize, appear as broad smear, not sharp peak on electrophoresis. Easily misinterpreted. Despite polymerization, hyperviscosity not common, lacks J-chain facilitated dimerization seen in IgM. Critically, light chains absent from serum marine. Key diagnostic feature:
Primary clinical signs.
chronic diarrhea, weight loss, severe malabsorption, intestinal involvement, extensive mesenteric periaortic adenopathy, respiratory tract involvement rare. Clinical course varies widely. Some chronosendolent, others develop aggressive lymphoma histologies, transformation, worse prognosis.
Treatment for alpha heavy chain disease. Infectious link influence therapy.
Chemo can produce long-term remissions. Uniquely, rare patients respond dramatically to antibiotics alone. Suggest role for chronic antigenic stimulation, maybe intestinal infection like Campylobacter jejuni. Chemo plus antibiotics may be more effective than chemo alone sometimes. Immunoproliferative small intestinal disease, IPSID, linked to alpha-heavy chain disease, recognized as infectious pathogen-associated lymphoma, CJUNI. Involves proximal small intestine, malabsorption, diarrhea, pain. Critically, early-stage IPSID responds impressively to antibiotics, 30–70% complete remission. Remarkable. Untreated IPSID often progresses to aggressive lymphoma. Non-responders to antibiotics get chemo, low-grade lymphoma regimens.
Finally, mood-heavy chain disease. Manifestation. Distinct features.
Exceedingly rare. Secretion of isolated MUNA-heavy chains seems to occur in very rare subset of CLL patients, not primary plasma cell dyscrasia. Only distinguishing features from typical CLL might be vacuoles and malignant lymphocytes, and unique excretion of kappa light chains in urine, despite no complete antibody in serum. Diagnosis needs specialized labs, ultracentrifugation infiltration, to confirm non-reactivity with light chain reagents. Some intact macroglobulins might falsely fail interaction. Tumor cells seem defective in light-heavy chain assembly, contain both but can't assemble secrete complete antibody. Treated same as other CLL patients, underlying malignancy dictates therapy. #Allerbeitsche.
Wow, what an absolutely incredible deep dive. We've journeyed through the intricate world of plasma cell disorders, started with antibodies, saw how precision goes awry, how they're meticulously diagnosed, and the incredible evolution of treatment, from chemo to cutting-edge cellular therapies.
It's been a masterclass in complexity. We've seen the M component as a red flag, but needing nuanced interpretation. Explore the intricate dance in the bone marrow, specific mutations in WM, unique presentations of POEMs and heavy chain diseases. Highlights the profound complexity and fascinating specificities.
Truly a masterclass in how a thorough understanding of biology informs every step, transforming lives. So for you, our dedicated learner, mastering this like an elite professional, here's a provocative thought. As we learn more about the genomic landscape and targeted therapies become more precise, what's the ultimate next frontier? Could we reach a point where these aren't just managed, but truly prevented through early intervention based on subtle biomarkers long before symptoms appear?
That's a powerful question, isn't it? Considering how far we've come. From palliative care to durable remissions, the journey of discovery continues, driven by these insights and that very question.
Thank you for joining us on this deep dive. We hope you feel not just well-informed, but truly empowered with a professional-level understanding of plasma cell disorders. Until next time, keep that curiosity alive and keep digging deeper.